Minnesota.
Πολύ ωραία, σας ακούμε και σας βλέπουμε.
Ωραία. Παρουσιάσω στα αγγλικά γιατί μας παρακολουθούν και από εκεί.
Όπως θέλετε.
Okay, so thank you for the invitation. My name is Tsangaris. I'm one of the structural fellows at the University of Minnesota, and I did this case with Dr. Sharma. So it's a case of a TAVR in an extra large annulus. Our patient was an 80-year-old male with symptomatic severe aortic stenosis. He has a past medical history of ischemic cardiomyopathy with an EF of 20% and known unrevascularized CTOs of the SHIRT and the RCA. On the baseline echo, we see restricted motion of the aortic valve, severely reduced LVEF, and an aortic valve area of 20. And on dobutamine stress testing, patient had contractile reserve and his gradients went up to 40, justifying severe low gradient aortic stenosis. The coronary angiogram showed a patent LAD with collateral flow to a large OM and an RPDA. And on pre-procedural planning, we got an annular area of 745 with a perimeter of 100. And fanning from the LVOT towards the sinus of Valsalva, we can see that there's minimal calcium on the annulus and some only modest amount of calcium at the tips of the leaflets. The valve is a tri-leaflet valve. In terms of the coronary heights, the left main is at 17 millimeters and the RCA at 21. The STJ is at 27 millimeters with diameters of 32 by 34. In terms of the calcium score of the aortic valve, we measured 1700 Agathon units. And here's the hockey puck view on Trimentio. And we can also see here that the calcification is definitely not severe, more like mild to modest. So in summary, we have an annular area of 745 millimeters squared and a perimeter of 100. We have plenty of sinus of Valsalva. The STJ height is good and the coronary heights are cleared for any commercially available valve in the US. During the heart team conference, the patient was thought not to be a surgical candidate due to his comorbidities, high risk, and actually patient preference. So we had to assess for percutaneous options. And from the 3 available valves in the US, of course, we were outside the IFU. The evolute effects would be a good option. Definitely we thought about it, but we would have to do a shallow deployment in order to get the maximum diameter of the stent frame. And due to the low calcium, we felt like the risk for embolization would be high. So we went with the Edwards platform. With a 29 millimeter deployment at nominal, we would be 13% undersized. And if we added 7 mLs, we would be 5% oversized. And with 8 mLs, we would be 7.8% oversized. And we definitely did not want to go higher, as in our own institution experience, when we inflated ex vivo at 10 mLs, we burst the balloon. On pre-procedural planning, again with Rimentio, we implanted a 29 virtual valve, and it looked small. And then thinking that with overinflation of a 29 millimeters, we would be able to achieve around 31 millimeters, we did a virtual implantation of a 31 millimeter valve, and that looked better. So this is our deployment. We used a 29 millimeter Resilia with nominal +8 mLs of volume. The valve appears well expanded and there is significant foreshortening as expected. And this is the post-deployment aortogram without any AI. This TTE 1 day post the procedure. There's no coaptation gap, there's no PVL, and the mean gradient is 2. And one month after the procedure, gradient is 4, and again, there's no AI. We did a CAT scan in order to assess our result. It appears going from the inflow towards the mid and the outflow of the valve. The shape is circular, the valve appears well expanded, and we have cleared the coronaries. Our valve diameter mid-strat at the mid-level is 30.2, and we have no coaptation gap, no leaflet restriction, acceptable gradients, and no leaflet tears. There are two considerations for a successful outcome in TAVR in extra large annuli, procedural and anatomical. Most publications describe adding 1 to 7 mL in a 29 millimeter sapien valve. We decided to add 8, consider the risk that this would be a large amount of volume. However, because the calcium burden was low, and because we didn't have any LVOT or annular calcium, we proceeded and we got a good outcome. We know that overinflation translates in overexpansion of the S3, and on a 29 millimeter, most observational studies have shown 1 to 2 millimeters expansion. And this is with ex vivo studies, but also with CT assessment post-deployment. Now, adding up to 4 additional cc's does not appear to cause any early or mid-term valve dysfunction. Contrary, bench testing of overexpanded 23 or 26 millimeter valves at extra 10% of the volume in the Atrium device had unfavorable hydrodynamics. That's not true for the 29 millimeter valve, and that might be possible due to the redundancy of the leaflet on the 29 millimeter, that we do not see coaptation gaps. Of course, valve frame has its limits, and this is due to the fabric seal and the constraints of the valve frame. In terms of the anatomical considerations, the degree of valvular calcification matters. Definitely in heavily calcified valves with a high Ackerson score, there's no need to inflate so much the valve. You will get good anchoring and a good seal probably with adding less cc's. And you can even do valves that are above 800 millimeters squared in area. Another consideration is the leaflet morphology. Bicuspid valves, especially the ones that taper down as we're going from the annulus to the sinus of Valsalva, they can seal in a level higher than the annulus. So the pre-procedural CAT scan is of huge importance, and the ring method is important to see if we can seal higher and essentially do a more safe deployment. In that case, we also use the intercommissural diameter to choose our size. And then lastly, the sinus of Valsalva, we have to make sure that they're not congested. The LVOT size, if it tapers down, is important because, especially if it's calcified with protruding calcium, with the sapien platform, there's a risk of rupture. And then we have to remember that even if the valve is clearing the STJ, the balloon can actually get in touch with the sinutubular junction, so we have to be cognizant about the size to avoid any injury there. So the take-home points are the treatment of extra large annuli outside the IVU is possible. The percentage of overexpansion depends on anatomic factors. The 29 millimeter S3 can be safely overexpanded up to 30.5 millimeters without any central AI, up to 8 millimeters above nominal. Further expansion might be achievable, but it might result in central leaflet injury. And overexpansion is, of course, best avoided under clinical circumstances unless clinical circumstances are compelling, as the best hemodynamic function of the valve is at nominal, and then long-term durability is unknown. Thank you for your attention.
Thank you very much for this excellent presentation, a difficult case about a problem that it's not very common, but requires special consideration, especially in the pre-planning contemplation of the procedure. Do we have any comments from our commentators?
Yeah, Matti, good to have you here, even by web. So, if you had the availability of an accurate or a MyValve, would you place, let's say, MyValve 32? You think it seems 473 square millimeters is good for a MyValve? It's a nominal dimension. So, but I suppose. In the same clinical scenario that you don't have, you have a properly sized LVOT with not a lot of calcification and not very low sinotubular junction. So maybe would you still do that to overinflate a Sapien 29 as opposed to use a MyValve 32?
I'll be honest, I don't have experience from the MyValve valve. Probably, if it's safer, yes, I would do it. Most of my experience is with the Edwards and the Medtronic platform, as the other ones are not FDA approved. I don't know, what's your experience?
Yes, Antoniadis Mastrokostopoulos has experience with both valves. What would you do?
Hi, great presentation. Thank you very much. So I would probably go with the MyValve platform. Actually, my case is a large annulus also with the MyValve system. So if we have a valve that we can choose, and it's actually, you can inflate it in the nominal ml that the company provides us, then it's much more safer than to, let's say, upgrade with another valve. So if the other anatomical characteristics are okay, I would prefer definitely the MyValve platform, and not go with an Edwards and just overinflate.
One quick question to you, Dr. Tsangaris. In case the valve had a lot of calcium, would that change your plan in terms of overinflation?
Yes, 100%. Actually, that's one of the most important factors. We have done, valves that measure 780 that are heavily calcified, 6,000 of calcium, and we did 29 plus 3 plus 4. So actually it would be risky to be so aggressive. And I think an individualized approach should be pursued. So again, I stress the importance of doing pre-procedural planning with the CT and, discussing with the cardiac imagers. So definitely avoid so aggressive inflations with heavily calcified valves.
Yes, thank you. I see Dr. Bousoula. Do you have a comment on this presentation?
Hello, everybody. Unfortunately, I haven't seen the presentation from the beginning. It's very interesting, and I think it's very useful that we have a lot of choices for patients with larger annulus. But unfortunately, I haven't seen the presentation from the beginning. Sorry.
Good. So we have to leave it there. And so the next